There'll be a little bit of overlap with the previous speaker, but I'll try and emphasize different aspects. So this would be antiplatelet agents in PCI. So this is the kind of busy diagram which immediately puts us all off learning anything about platelets because it's all much too complicated. Here's the platelet, and here's the cascade that goes through ADP, P2Y12, thromboxane A2, etc., activation with COX-1, glycoprotein 2B, 3A. It's all designed to make sure that only geeks end up doing platelet activation studies. And if you thought that was bad, then this one is even worse. It sort of reminds me of those awful moments when I had to learn the Krebs cycle and never quite got the hang of it. So we've got COX-1, got thromboxane A2, glycoprotein 2B, etc. Slightly more helpfully, we've got the P2Y12 receptor, which many of the currently investigated agents are acting against. So we have the irreversible blocking of P2Y12 with Clopidogrel and Prasugrel, reversible with ticlopidine, which is pretty much no longer used, and Ticagrelor, and aspirin, which has a quite different mode of action blocking the COX-1. So looking at aspirin, this bit's pretty straightforward. Benefits of aspirin have been established for many years. 4 big studies showing that the outcomes with aspirin in unstable angina or STEMI are much better than those treated with placebo. So you can see in these 4 studies a really huge relative reduction and a large absolute reduction in death or MI in consecutive studies, all pointing in the same direction. So very good evidence about the value of aspirin. And so the recommendations in the guidelines are always that aspirin should be administered as soon as possible when they come to medical contact and continued indefinitely unless they don't tolerate it. And if they're having an invasive strategy, then they should have dual antiplatelet therapy on presentation, which I'll just come on to, and the class 1 evidence level A, so the highest recommendation. For those who actually get stenting, which is the key thing that I was asked to discuss, aspirin should be prescribed indefinitely, and the rest of the tablet medication I'll come on to now. So Clopidogrel, which came in, I don't know, about 10 years ago or so, when ticlopidine was there as a BD drug, which had occasional agranulocytosis, so it was a bit of a potential problem. Clopidogrel came in addition to aspirin, and the cure trial was done in the PCI cure trial, a separate aspect of it. Clopidogrel on aspirin versus aspirin alone showed substantial reduction in the endpoint of MI or cardiovascular death, with early divergence of the curves, but some gradual continuing divergence over time, which led to arguments about whether you could stop the Clopidogrel after a month, or did you need to carry it on for 12 months, etc. These are those curves, and you can see that the initial separation is quite early between these 2 curves in terms of overall long-term results from randomization to end of follow-up, and an overall 30% risk reduction, so quite a significant difference between placebo and aspirin and Clopidogrel and aspirin. So that became the standard of care, and we then were faced with the issue of, okay, so gradually it became clear that there was Clopidogrel resistance and that the speed of onset of Clopidogrel was suboptimal for particularly the highest risk patients coming in with, say, STEMI or sort of acute onset NSTEMI, and therefore loading doses were looked at. 300 milligrams had been the standard, 600 was proposed, and so looking at the ADP aggregation with these doses, it became clear that a significant proportion of people who were given 300 milligrams of Clopidogrel didn't get optimum antiplatelet effect in good time, and so 600 milligrams was used, and that's now still used whenever someone comes to new contact with medical personnel and a suspected unstable angina or STEMI. If you're going to give Clopidogrel, then you give 600 milligrams. 900 milligrams didn't make much difference, but of course did have a potential high risk of bleeding, so that hasn't been recommended. This also had an impact on very early stent thrombosis for the same reason. If you're giving an antiplatelet agent and it hasn't actually taken effect by the time you finish the procedure, of course there'll be a risk of stent thrombosis. So that's been a significant advance, 600 milligrams of Clopidogrel. Then Prasugrel came along, and this is an irreversible inhibitor of P2Y12. So it's essentially in the same class, same territory here with the Clopidogrel. This has been examined in some large studies. Of course, there's enormous amounts of money at stake here, so these are huge studies run by the companies that make the products. And this was double-blind, Prasugrel 60 milligrams loading dose, Clopidogrel 300 loading dose, and then 10 versus 75 going on from there for 12 months. And these were STEMI or unSTEMI, if you like. So there was a significant difference between these two agents, and this was reported, some years back. So it's intriguing in a way that it hasn't taken hold in the UK, but there's some good reasons for that. Clopidogrel, 12%, primary endpoint, Prasugrel, 9.9, so it was statistically significant. But if you balance that, if you like, against the problems that you're going to have with Prasugrel, so yes, maybe significantly fewer MIs, but some major bleeds, some of which can be very problematic. So what's your net clinical benefit? Maybe not quite as substantial, and there are. I'll just gloss over the unrevascularized patients because there wasn't much difference. But the problem with Prasugrel is you do have to be careful who you use it in. There was in the subsets there was significant higher risk of bleeding in patients of the elderly age group, and of course 75 and older. That's the majority of the stuff certainly that we see now, and quite possibly what you see as well. So that means you're not giving it to people over 75. You're not giving it to people who are of low body weight. Again, risk of bleeding. So whenever something comes in where you have to think instead of just giving them the tablets, that sort of halts its progress, because we don't really like to have to think very much before we give people their pre-tablets. It's just a party bag. They go eat that lot, and we'll just get you to the cath lab as soon as we can. So the recommendations for Thienopyridine use are Clopidogrel 600 during PCI and 75 milligrams thereafter for a variable duration, or Prasugrel loading dose of 60 with 10 milligrams daily thereafter. And so Prasugrel can be considered, and it's class 2B, level of evidence C, but with those misgivings and concerns that I've just discussed. Then we have Ticagrelor, which comes along. That's a cyclopentyl triazolopyrimidine, which is great because that means that the trade name is assured of being used always instead of the type of molecule. It's a direct and reversible mode of action. And I was briefed not to talk too much about Ticagrelor because that's going to be discussed in a minute in some detail. Most recently, the Champion Phoenix trial has been presented at the ACC with Cangrelor, which is an intravenous agent. It's an intravenous ADP receptor antagonist, and you get return of normal platelet function within an hour. So very clever, potentially very valuable if we can find a slot for it, if you see what I mean, and if it wouldn't be too expensive. It's been previously studied without meeting primary endpoints. Obviously, there's a niche for this if platelet function returns quickly, but in this trial, essentially they looked at all comers, at Cangrelor versus Clopidogrel in thousands of patients, and so what I would imagine is, yes, statistically significant, but perhaps for the drug company, slightly disappointing numerical difference in the primary endpoint of death MI stent thrombosis. Yes, a significant difference in stent thrombosis from 1.9 to 1.3. Is that going to be enough to warrant the use of an intravenous agent, an expensive agent? I don't know. No difference really in the other aspects of the primary endpoint. And of course, as has always been the case and was alluded to in the last talk, you can't at the moment get better antiplatelet action without getting more bleeding. And the more potent your antiplatelet is, the more the risk of the bleeding. And that was shown in this study as well. Clopidogrel was much better across the board in terms of the risk of bleeding. So in conclusion, the indications in PCI are fairly straightforward. They get a loading dose, a minimum of 2 hours before the procedure when it's stable or unstable. Of course, with STEMI, they have to get it the minute you've made the diagnosis. And the options include Clopidogrel 600, Prasugrel 60, or Ticagrelor 180. What tends to happen in this country is for stable patients, they'll get Clopidogrel 600. Unstable patients, depending where you work, will usually get Clopidogrel as well, but STEMI patients may well get Prasugrel because of the rapid onset of action. The duration after stent implantation is variable in different units, and there's a certain amount of disagreement. The guidelines would suggest that you should give these agents for a minimum of 12 months, but many places will stop Clopidogrel if a bare metal stent has been put in after a month and continue aspirin, and many places similarly for drug-eluting stent with the evolution of data showing that this is safe, many people will stop the Clopidogrel after 6 months for a drug-eluting stent. So that allows a greater flexibility in planning other procedures. And the drugs that there are either Clopidogrel, Prasugrel, or Ticagrelor, and that's the current state of play in what is gradually becoming a pretty complicated field. Thank you.
Thank you very much.